Welcome back. This is Dr. Mansoor Madani, Chairman, Department of Oral and Maxillofacial Surgery at Capital Health System in Trenton, New Jersey, and Associate Professor of Oral Maxillofacial Surgery at Temple University, Philadelphia, Pennsylvania. Thank you for listening to this segment of my presentation. Pain management is a complex issue to discuss and learn, so I've divided the 6-hour lecture into 5 segments. I highly recommend watching the 2-part series on fascinating history of opioid discovery and pain management. I assure you that you will find it extremely interesting and educational. As I covered pain management, prescription writing, PDMP, and many more relevant topics, this course should qualify as credit for Pennsylvania mandatory requirement for these subjects. Simply register on our website to receive the credit. Our website address is www.snornet.com or contact lisa@snornet.com. I enjoy doing these lectures and I love hearing from everyone. Please feel free to leave your feedback in the comment under the YouTube video and be sure to click on the share button and encourage your colleagues to listen to these presentations. During this presentation, I'm going to be talking about mechanism of action of narcotic as well as non-narcotic pain medications, effects, side effects of narcotics, sign and symptoms of opioid abuse, sign and symptoms of opioid overdose and opioid withdrawal, and also I'm going to discuss about Act 139 or David's Law 2014, which covers on Narcan law, principle for effective substance disorder treatment, and many more. So I hope you like this presentation. Sit back and relax and listen carefully. So before I speak about the mechanism of drug action, I would like to review the physiology of pain. How pain is transmitted and perceived is complex, in part because of the nature of the fully integrated and constantly changing structure of the central nervous system and the symphony of chemical mediators, only a fraction of which are understood. The pain experience begins with the nociceptors. A nociceptor or pain receptor is a sensory neuron that responds to damaging or potentially damaging stimuli by sending possible threat signals to the spinal cord and brain. If the brain perceives the threat as credible, it creates the sensation of pain to direct attention to the body part. So the threat can hopefully be medicated. This process is called nociception. There are afferent nerves that respond to nauseous stimulations. Different nociceptors may preferentially react to a specific kind of nauseous stimulus, such as mechanical stimulation or temperature sensation. Different types of nociceptors may be found in different sites. For example, the most common cutaneous receptors is the polymodal C fibers, which respond to the pressure, temperature, and chemical stimulation, whereas a skeletal muscle contains mostly chemoreceptors. All pain receptors have an initial high threshold to nauseous stimulus, which decreases with repeated stimuli. The signals, when these nociceptors are activated, must be transduced and transmitted to the spinal cord and brain, where signals are modified before they are ultimately understood or felt. In summary, when we look at the physiology of pain perception following an inflammation or an injury, there are multiple steps that takes place. They include transduction of that injury or information, conduction, transmission, modulation, and perception. I want to discuss this in a little bit more detail so that we have a good understanding of physiology of pain perception. First is transduction. During this stage, the inflammation or trauma triggers the damaged cell to release biochemical mediators such as prostaglandin, bradykinin, serotonin, and histamine that sensitizes nociceptors. Painful stimulation also causes movement of ions across cell membrane, which excites nociceptors. Pain medication can work during this phase by blocking the production of prostaglandin. For example, in cases that we use ibuprofen or aspirin, or by decreasing the movement of ion across the cell membrane, for example, when we use local anesthetic agent. I will explore this in just a moment. Next step is conduction. During this phase, the action potentials passes along neurons. Sodium and potassium serum level may affect pain threshold. Look at the threshold of activation after an injury in this slide. Next step is transmission. During this phase, there are synaptic transfer of inputs from one neurons to the next using chemical messengers or neurotransmitters. And we will talk about neurotransmitters in just a moment. This phase includes 3 segments. During the first segment, the pain impulse travels from the peripheral nerve fiber to the spinal cord. During the second segment, transmission from the spinal cord to ascending tract via spinothalamic tract moves up to the brainstem and thalamus. Third segment involves transmission of signals between thalamus to the somatic sensory cortex where pain perception occurs. Pain control can take place during this second process. Opioid blocks the release of neurotransmitter, which stops the pain at the spinal cord level. Next is modulation, an anti-nociception phase, where neuron originating in the brainstem descend to the spinal cord and release chemical messengers that inhibit transmission of painful stimuli. In other words, modulation occurs when neurons in thalamus and brainstem send signal down to the dorsal horn of the spinal cord and have the most important role in pain modulation. Modulation for this reason is called descending system. The descending fiber releases substances such as prostaglandin, endogenous opioids, serotonin, histamine, acetylcholine, and norepinephrine, which inhibit the ascending painful impulses in the dorsal horn. The final phase is perception, recognition, and reaction in the brain. Complex interaction involve thalamus, which is the master switchboard, the sensory cortex, limbic system, and reticular activating system. Obviously, this is when we become conscious of the pain. The body's response to pain has both physiologic and psychological aspect. The symptomatic nervous system responds, resulting in fight or flight response with noticeably increase in pulse and blood pressure. The person may hold his or her breath or have short, shallow breathing. Now that we understood the physiology of pain perception, let's just look at the process of pain one more time. After a physical, chemical, or an inflammatory stimuli, cell produces and releases prostaglandin. Prostaglandin is synthesized in virtually every cell in our body. When we use a narcotic drug, they affect at a cellular level. As I said before, when there's a tissue injury at cellular level, in presence of phospholipase A2, arachidonic acid is produced, and in presence of cyclooxygenase, prostaglandin is released, that you see on the right-hand side of slides, and on the left-hand side, arachidonic acid in presence of lipooxygenase releases leukotriene. Leukotrienes are controlling inflammation, but prostaglandin, they control pain, inflammation, fever, and platelet aggregation. When we use steroid prevents release of arachidonic acid. When we use non-selective NSAID, they work at that cyclooxygenase 1 and cyclooxygenase 2, or COX-1 and COX-2. and they control pain, inflammation, fever, and platelet aggregation. Prostaglandins promote inflammation, pain, fever, blood clotting function of the platelets, protect the lining of the stomach from damaging effect of acid, and prostaglandin is a potent cell signaling molecules. Prostaglandins sensitize the nerve cell to pain, increase temperature, and convey messages to pain receptors or nociceptors in spinal cord and then finally to brain. Looking back at the illustration I just showed you, when we look at the arachidonic acid and in presence of cyclooxygenase breaks down to prostaglandin, there are two types of that cyclooxygenase, or COX-1 and COX-2, that we have learned in past. COX-1 or cyclooxygenase 1 protects the stomach, helps with platelet aggregation or clot formation. COX-2 produces prostaglandin that promotes inflammation and pain and fever. Selective non-steroidal anti-inflammatory such as Celebrex and Bextra work on the cyclooxygenase 2 that produces prostaglandin that promotes inflammation, pain, and fever without causing harm to the GI system. Aspirin, for example, is a unique NSAID, but it blocks both COX-1 and COX-2, just like other NSAIDs. It reduces inflammation, pain, and fever, but inhibits clotting of blood for a prolonged period of time, between 4 to 7 days. Most NSAIDs inhibit the clotting of the blood for only a few hours, but aspirin is prolonging that for between 4 to 7 days. Aspirin, as far as its blood thinning effect or pharmacodynamic of function of aspirin, is it inhibits platelet aggregation, the clumping of the platelet to form blood clot, by interfering with thromboxane A2 production, a substance necessary for platelet aggregation. It enhances blood flow during MI. One of the latest information that was released by Lancet in July of 2018, it said that it is most beneficial if patients' body weight is between 110 to 154 pounds, and if they are extremely obese, the using of baby aspirin may not be as effective. How about drug interactions of aspirin and other medications that patients may use? First is potentiating effect, risk of toxicity, and increase the anticoagulation effect of heparin, Coumadin, Plavix, Xarelto, Perdaxa, and Eliquis. Also increases toxicity with methotrexate, used to treat cancer of the blood, bone, lung, breast, head and neck. Also is used to treat rheumatoid arthritis and psoriasis. It increases their level of methotrexate in the body when aspirin is also used at the same time. Anti-diabetic agent may increase the risk of hypoglycemia for patients that they are diabetic. How about the reducing effect or ineffectiveness of other medication? Corticosteroid and antacid decreases plasma salicylate level, increases the risk of ulcer. And with ACE inhibitors such as lisinopril, beta blockers such as biastolic metoprolol and atenolol, antihypertensive effect may be reduced and causes increased blood pressure. Just a point of to remember, when patients are on ACE inhibitors such as lisinopril, you have to watch out and alert the patient about angioedema, and which is a significant but rare side effect of allergic reaction to ACE inhibitors, including lisinopril. The other most commonly used non-narcotic pain medication is acetaminophen or Tylenol. It inhibits the synthesis of prostaglandin, so it's controlling the pain, directly affecting hypothalamus for fever. Unlike aspirin, it does not affect inflammation or platelet function. More than 100 over-the-counter medication may contain acetaminophen. It is most common over-the-counter drug involved in overdose. What is the maximum daily dose of acetaminophen? Basically, it's 4 grams if you're younger than 60 years of age and have a functioning liver and kidney and no history of alcohol abuse. 3 grams for older patients than 60 years of age. 2 grams if someone has liver or kidney disease and history of alcohol abuse. That's the maximum daily dose of acetaminophen. Now we know how non-selective NSAIDs work. They inhibit prostaglandin synthesis by blocking both enzymes COX-1 and COX-2. Blocking COX-2 reduces prostaglandin inflammation, pain, and fever. COX-1 reduces prostaglandin that protect the stomach and support the blood clotting, so NSAIDs can cause ulcers in the stomach and promote bleeding. Example of non-selective NSAIDs or the COX-1 and COX-2 inhibitors are ibuprofen, such as Motrin and Advil, naproxen, such as Aleve or naproxen and Anoprax. The other medications such as Toradol, Voltaren, Codeine, and Indocin are examples of non-selective NSAIDs. So now that we know about non-selective one, how about the selective NSAID? That they only selectively block COX-2 enzymes. They inhibit prostaglandin synthesis. They have analgesic effect, relieve pain, anti-inflammatory effect with far less GI adverse effect. The only one that is remaining right now are Celebrex and Bextra, and one of my favorite drugs was used to be Vioxx, but because of the misinformation and many lawsuits about heart attack cases, that Vioxx was withdrawn from the market. But at this time, the selective NSAIDs are Celebrex and Bextra. Celebrex drug interaction with ACE inhibitors such as lisinopril, beta blockers such as biastolic, metoprolol, and atenolol, it reduces their effectiveness of them. But it increases Coumadin and other blood thinners' effect by prolonging the bleeding. It also increases and interacts with herbal preparation, increases risk of bleeding with ginger, garlic, red clover, and horse chestnut. So let's compare narcotic and non-narcotic. And as an example of narcotic, I use aspirin. Of course, the analgesic effect of narcotic is much more stronger, but aspirin is a weak analgesic. Type of pain relieved by narcotics are any type of pain, but with aspirin are musculoskeletal pain. Mechanism of action of narcotic, as we explore it in just a moment, is a stimulation of opioid receptors. And with aspirin is inhibition of prostaglandin synthesis. As far as anti-inflammatory or antipyretic effect, narcotics, they do not have either of those. Aspirin has both of them. Or they can create anti-inflammatory and antipyretic effect. Tolerance and dependence and addiction is obviously very common with narcotic, but not in existence with aspirin. So non-narcotic drugs affect at a cellular level, while the narcotic function at central nervous system level, which includes brain and spinal cord and peripheral nervous system as well, including nerve fiber that goes to all parts of the body and sends signal to different tissues and sends signal back to the central nervous system. So narcotic effect on nervous system. Now I want to review some very basic concept of nerve cell. The nervous system is made up of over 100 billion neurons. Neurons communicate with each other using axon and dendrites. When a neuron receives a message from another neuron, it sends an electrical signal down to the length of its axon. At the end of axon, the electrical signals in form of action potential are converted into a chemical signal, and the axon releases those chemical messengers called neurotransmitters. Neurotransmitters. There are many types of neurotransmitters that are released in the body, including adrenaline, GABA, which has calming effect, norepinephrine, which helps with concentration, acetylcholine, which helps with learning, dopamine with pleasure, glutamate with memory, serotonin with mood, and endorphin with euphoria. So let's look at them carefully. First is adrenaline, which is the neurotransmitter responsible for fight or flight. Produced in a stressful situation, increases heart rate and blood flow, leading to physical boost and heightened awareness. The next neurotransmitter is GABA, which has the calming effect, calms firing nerves in the central nervous system. High level improves focus, low level causes anxiety, also contributes to motor control and vision. Norepinephrine helps with concentration, affect attention and responding action in the brain, contracts blood vessels and increases blood flow. Acetylcholine involves in thought, learning and memory. Activates muscle action in the body, also associated with attention and awakening. Dopamine is the next neurotransmitter that controls the feeling of pleasure, also addiction, movement and motivation. People repeat behaviors that lead to dopamine release. Glutamate is the most common neurotransmitter involved in learning and memory. It regulates development and creation of the nerve contacts. Serotonin contributes to well-being and happiness, helps the sleep cycle and digestive system regulation, affected by exercise and light exposure. And finally, endorphin, which is released during exercise, excitement, and sex, produces well-being and euphoria, reduces pain. Why do people abuse drugs? Those drugs mostly affect motivation and pleasure pathway of the brain. Now that we know the neurotransmitter, there are two particular neurotransmitters responsible for that, and they are dopamine and serotonin pathway. The dopamine and serotonin pathway are the two neurotransmitters affected by drugs of abuse. They are illustrated here by altering activities in this pathway. Abused substances can influence their function. Dopamine neurons, shown in yellow, influence pleasure, motivation, motor function, and importance of a stimuli or event. Serotonin, shown in red in this picture, plays a role in learning, memory, sleep, and mood. Beside that, again, when we look at the summary of the function of dopamine, it helps with motivation, which is the reward center, social interaction, pleasure, euphoria, motor function, and craving, desire, urge, preservation, protection, and support. And serotonin function controls mood, as I said, memory processing, sleep, and cognition. So let's review some basic steps in synaptic transmission in reward center. On the left-hand side, we see a picture of dopamine neuron. And then at the bottom of it, we see a receiving neuron. So we have the dopamine sending neuron and then receiving neuron. In between them is synapses, where dopamine receptor proteins are located in the receiving neuron. The first step is the dopamine neuron. Neurotransmitters are made and released by those neurons. Then, of course, dopamine neuron releases dopamine in the second step, which is the middle picture, and that is released in the synapses area or synaptic area. During the third step, on the right-hand side of this picture, the neurotransmitter receptors are activated. Dopamine binds the dopamine receptor protein This causes the portion of the protein on the inside of the receptor to be released and carries the signal onward in the receiving cell. Finally, it is important to remember some dopamine molecules return back to the synapses and are absorbed back in the sending neuron. The bottom line is that we do not want too much dopamine in the synapses. I'd like to look at it a little bit closely as we talk about drug addiction and see how drug addictions occur. If you look at this illustration, what is schematically illustrated in this slide is a nerve terminal on the top, the synaptic cleft or space between the neuron and the postsynaptic or receiving portion of a dendroid on a neighboring neuron. Dopamine is contained in vesicles around the storage units in the nerve terminal. Dopamine receptors are present on the receiving neuron. When a signal comes down the axon, dopamine, shown in orange, is released into the synapses. It then crosses the synaptic cleft to the second neuron, where it binds to and stimulates dopamine receptors, shown in blue in this picture, generating a signal in the second neuron. The dopamine is then released from the receptor and crosses back to the first neuron, where it is picked up by the dopamine transporter, the reuptake molecule shown in purple in this picture, for reuse. Shortly after the discovery and observance of endogenous opioid peptides, multiple classes of unique opioid receptors were discovered. They included mu receptor, delta receptor, kappa receptor, and ORL1 receptors. And then they discovered that these opioid receptors are found in central nervous system, in the cortex, thalamus, spinal cord, in the peripheral neurons, inflamed tissue, immune cell, respiratory tract, and GI tract. But what happens when a person takes a drug? This slide shows how cocaine is able to alter activities in the synapses. Cocaine, shown in green, attaches to the dopamine transporter, shown in purple, thereby blocking dopamine from being taken back up to the first neuron. Thus, dopamine can continue to stimulate, maybe overstimulate the receptors of the second neuron because it remains in the synapses for a longer period of time. This duration of a stimulation and amount of dopamine in the synapse is far greater than what normally occurs when a person engages in an enjoyable activity, for example, eating, sex, or so on, and is what produces cocaine's intense euphoria and potential for abuse. Similar situation happens with use of methamphetamine, which floods the synapses by releasing lots of dopamine in synaptic cleft. Heroin also binds the dopamine receptor in the receiving neuron and also floods the synaptic cleft with a lot of dopamine. So when drugs flood those synapses, it gets hyperactivated and produces euphoria. It rewires the brain wanting more and more, leading to drug addiction. Now, let's look at pharmacokinetics of opioids. First, opioids are lipid soluble, but they are absorbed also from nasal, buccal mucosa, and the skin, but the general absorption is in the GI tract. They are biotransferred in liver, and they are excreted through kidneys and GI system. Their elimination rate is different by age and gender. When we talk about pain, pain consists of both sensory and affective or emotional component. Opioid reduces both aspects of the pain, sensory and especially the affective aspect. In contrast with narcotics or opioids, non-steroidal anti-inflammatory have no significant effect on the emotional aspect of pain. And this is important to understand when we talk about drug addiction and narcotic addiction in particular. How about the side effect of narcotics? They include nausea, vomiting and dry mouth, itching and sweating, sleepiness and dizziness, confusion, depression, low level of testosterone that can result in lower sex drive, energy and strength. Other side effects include sedation, drowsiness, loss of coordination, miosis or constriction of the pupil, as you can see in this picture, increased intracranial pressure due to vasodilation, hypothermia, bradycardia, and hypotension are other side effects of these medications. As I said, there is peripheral arterial and venous dilation that cause hypotension, and also hypotension is due to depression of vasomotor center and release of histamine. The effect on respiratory center when we use narcotics is as follows. It may cause acute respiratory failure, causes truncal rigidity, reduces and interferes with ventilation. But on the other hand, codeine is a great cough suppressant and is dispensed in form of promethazine with codeine cough syrup for control of cough. But use of narcotics during pregnancy. If chronically using opioid, the fetus may become physically dependent in utero and show withdrawal symptom in the early postpartum period. Patients that use heroin, every 19 minutes an opioid addict baby is born in the United States because of heroin use during pregnancy. An interesting fact about narcotic is that narcotic causes constipation and sometimes severe constipation, creating intestinal herniation, rupture due to narcotic consumption, and severe constipation. It is said that Elvis Presley, who died from cardiac arrest, also had severe constipation from substance abuse. There are lists of medications that are used as a co-analgesic or adjuvant toolbox to use to manage pain. Here is a list of drugs that are non-narcotic, but they are used as a co-analgesic for managing pain. Medications such as antidepressant, for example, Elavil or amitriptyline and nortriptyline are first line of treatment for neuropathic pain. Calcium channel blockers such as gabapentin or pregabalin are also first line for treatment of neuropathic or lancinating pain. Anti-anxiety medications such as Effexor also are used as first line of treatment for neuropathic pain. Anti-arrhythmic pain medications such as lidocaine is first line of dermal or and also dental anesthetic. Antidepressants such as Zoloft are the second line for neuropathic pain. Baclofen is used for spasms and nociceptive relief of pain. Corticosteroids such as dexamethasone are used for bone pain. Bisphosphonates such as Zometa and Reclast are used also for bone pain in multiple myeloma. And finally, ketamine, that is used as an adjunct to anesthetic, is under classification of NMDA receptor antagonist, that is commonly used as an adjunct to anesthesia. Now let's look at them a little bit in more detail. FDA approved some anticonvulsant medications for post-therapeutic neuralgia and partial and complex seizure. They include gabapentin or Neurontin, Lyrica, and Topamax. They're good for neuropathic pain, pain due to nerve injury, sensory neuropathy, and migraine and fibromyalgia. Gabapentin or Neurontin, the dosage of this medication is 100 to 600 milligram, Usually they start at 300 milligram daily, then is increased up to 600 milligram TID after 8 days. May cause drowsiness, dizziness, and vision changes. Tramadol or Altram is an opioid analgesic. Limit prescribing it for about 5 days with no refill. Tramadol is used for moderate to severe acute pain. The dosage are 50 to 100 milligram every 4 to 6 hours PRN pain, with a maximum dose of 400 to 600 milligram daily. Avoid prescribing it to patients with a history of drug abuse or hepatic problem. Many drug interaction and side effect of tramadol includes high body temperature, seizure, agitation, sweating, dilated pupil, and diarrhea. Tramadol advantages and disadvantages. Less respiratory depression, nausea, vomiting, constipation than codeine or oxycodone. Less abuse potential, rapid psychomotor recovery, increased seizure risk when combined with opioids, and suicidal warning for tramadol includes when used with antidepressant and due to altered mental status is a warning that comes with tramadol package. Methadone was developed in Germany in 1937 for treating pain. Introduced in the United States in 1947 by Eli Lilly, used for managing chronic pain. Similar action to morphine and heroin, may have greater efficacy in neuropathic pain. It can be used to wean heroin and morphine addicts off the drug, but it can lead to psychological dependence, less problem with withdrawal, highly lipophilic, and good in renal dialysis cases. So now let's look at some of the signs and symptoms of opioid abuse. In addition to a known history of opioid abuse, we may see a slow or absent respiration, weak pulse, constricted pupil or miosis, weakness and unresponsiveness, constipation, nausea, and vomiting. They could be among some of the symptoms of opioid abuse. Now, let's divide those signs and symptoms of opioid abuse and addiction. We're going to look at medical sign, psychological sign, social sign, behavioral sign, and financial signs of addiction and abuse. As far as medical signs, patients, they may have slurred speech, confusion, impaired judgment. Sometimes they would have itching all over their body, and flushing of the skin is also observed as one of the opioid abuse and signs of addiction. When we look at the psychological signs, mood swings, going from feeling of euphoria and positivity to despair, depression, and even anxiety, poor performance at work or even at school. And under social signs of addiction, we see people being involved in stealing or borrowing money to support their habit, stealing drugs from the medicine cabinets of friends and family members. And we also see doctors shopping, going to different physicians and feigning injuries or illnesses to obtain more narcotics. Other signs of addiction includes withdrawal symptom when not taking the drug, reckless behavior such as driving while under the influence of narcotics, and secretive behaviors. Finally, financial signs. Financial problems such as running up credit card bills to purchase narcotic from internet-based pharmacies, and stealing. Those are financial signs of addiction. Of course, I have to add that those signs are not universal and not always indicative of addiction, but they are among some of the signs that we see for a variety of financial, behavioral, social, and psychological and medical signs of addiction. So how about signs of overdose? Slow pulse or pulselessness, blue lip or fingertips. Pale face, vomiting, choking are amongst few of those signs of overdose. What are the reversal agents used for narcotic overdose? Narcan or naloxone is one of them. It antagonizes all morphine and opioids actions. One spray on each nostril works just fine. Works within 3 to 5 minutes, wears off in 30 to 90 minutes. It does not reverse opioids. Overdose can come back after that period. So that's something that when Narcan is used, we have to watch out. So Narcan is used to reverse the life-threatening respiratory distress of opioid overdose. It works on heroin overdose. Oxycodone, hydrocodone, fentanyl, and methadone overdose will not reverse the effect of buprenorphine and pentazocine, not a controlled substance, not addictive, and it is safe to be administered by intramuscular injection or intranasal administration. In the United States, in 2014, a Narcan law was passed. It is called Act 139, David's Law of 2014. Basically, it says that police, EMS, and firefighter, obviously, they can use Narcan, but it also provided to individual or the family of someone who may have an addict in their house. Good Samaritan portion of the Act provides civil liability protection to those responding to and reporting the overdose. Drugs that are used to combat addiction at this time are buprenorphine and methadone that are they act by reducing craving and withdrawal. Buprenorphine is an opioid and it works by activating the same opioid receptors that I talked earlier that other opioids are attached to at a lower level without causing a high. Suboxone is a combination of buprenorphine and naloxone. Buprenorphine is a semi-synthetic opioid, has a slow onset and highly bounded to opioid receptors, comes as a sublingual film. It requires a partial detoxification process, usually 12 hours to 2 days, and is useful for moderate pain as well. The detox medication is called Vivitrol. It's an extended release formulation of naltrexone, an opioid receptor antagonist, and is given as a monthly IM injection, but is very expensive. It's about $500 per injection. The pill form of Vivitrol is generally cheaper. It blocks craving and effects of use of narcotic. It requires full detoxification to be effective and to use, usually 3 to 10 days of no opioid use. Downside of both forms of this drug is patient compliance. Let's look at several principles for effective substance use disorder treatment. We have to understand that addiction is complex but treatable disease that affect brain function and behaviors. No single treatment is appropriate for everyone. Treatment needs to be readily available. Effective treatment attends to multiple needs of the individual, not just his or her drug misuse. The National Institute of Drug Abuse also adds remaining in treatment for an adequate period of time is critical. Behavioral therapies, including individual, family, or group counseling, are the most commonly used form of drug misuse treatment. Also add that medications are an important element of treatment for many patients, especially when combined with counseling and other behavioral therapies. An individual's treatment and services plan must be assessed continuously and modified as needed to ensure that it meets his or her changing needs. Many drug addicted individuals also have other mental disorders as well. Medically assisted detoxification is only the first stage of addiction treatment and by itself does little to change long-term drug misuse. Treatment does not need to be voluntary to be effective. Drug use during the treatment must be monitored continuously as lapses during the treatment do occur. One additional thing, treatment programs should test patients for the presence of HIV or AIDS, hepatitis B and hepatitis C, tuberculosis and other infectious diseases, as well as provide targeted risk reduction counseling linking patient to treatment if necessary. When we talk about drug-related suicide, relapse is the main leading cause of drug-related suicide. Unfortunately, over 50% of patient relapse after drug rehab. So we have emotional relapse, mental relapse, and physical relapse. There are then opioid withdrawal symptoms, that they are psychological and physical symptoms of opioid withdrawal. Psychological, such as anxiety, restlessness, irritability, insomnia, headache, poor concentration, depression, and social isolation. The physical condition of physical symptoms of opioid withdrawal include sweating, heart palpitation, muscular tension, tightness in the chest, difficulty breathing, tremors, nausea, vomiting, and diarrhea. Technology that they may help with opioid withdrawal, including this systems called the bridge pain device helping with opioid withdrawal. There is deep brain stimulation, resetting the addictive brain. This is a technology that is being used now for Parkinson's disease. Placing a probe to treat certain neurons may be the new method of treating addiction. And that is something that worth exploring as well. In a patient, it is important to use universal precaution as far as writing a narcotic prescription. We need to have diagnosis with appropriate differential, psychological assessment, including risk of addiction. There are informed consent form that you can explain, and also informed written consent form. Same with treatment agreement, and pre and post intervention assessment of the pain level and patient's function. This is an important concept: a patient and prescriber agreement, a consent form. First, patient has to initial it, and the provision is, I shall obtain controlled substances from only one prescriber. Controlled substance prescription shall be filled at a single designated pharmacy. Using PDMP would solve that problem. Certain steps shall be taken to safeguard controlled substance prescription by patients. And patients, they have to agree that and say that I will not store controlled substances in a medicine cabinet. I will keep it away medication in a locked cabinet or locker. I will not share or sell my medication. I will return for follow-up visit at a specific intervals. I will submit to random drug testing, urine drug testing when required. And I will contact my prescriber for controlled substance prescription refill only when I need it. Drug seeking behavior will lead to discharge from the practice. This is a good, simple consent form to be used by prescribers. The other important part of the universal precaution is appropriate trial of opioid therapy and or adjunctive medication, reassessment of the pain score and functional level, regular assessment of the 4 A's: analgesia, activity, adverse reaction, and aberrant behavior. Also, periodic review of the pain diagnosis and comorbid conditions, including substance use disorders, and also documentation, which is really, really important. Treatment agreement includes review of the benefit and risk of opioid therapies in plain, understandable language. It protects you, the prescriber, when discussing the agreement, when the discussion of the agreement is documented. Explain inappropriate use and consequences if agreement is broken, and discuss tools that will be used for monitoring the patient. So in treating addiction, we need to keep our eyes on the real target. It could happen to any family. Recognize and support abstinence and functionality in family, work, and community are the goals of keeping the patient out of addiction. The bottom line of this presentation is be vigilant and use alternative medication. Narcotics should not be the first line of treatment for milder to moderate pain. Using ibuprofen and acetaminophen as an alternative measure has been worked very well in majority of dental situations. And I hope that you enjoyed this presentation. This concludes the second part of our presentation, and please continue to watch the rest of these presentations, as they are really interesting and important. I look forward to talk to you in my next part of the presentation.